You can also see that when similarly from this data in Malawi, when self-testing was done at health facilities, there was a 53% reduction in the time that it took for a healthcare worker to be involved in testing. And so then you could reallocate that healthcare worker time somewhere else. And so that's really important, right? It allows the healthcare workers to focus on things that require their clinical skills, and it allows someone to have access to testing more quickly. And also just on the far side, and you can see the hyperlink later for more details of this methodology, that if we had and we utilized more routinely a $1 self-test, this would be more cost effective than our current PIT-CT models or any sort of risk screening. And so we need to be thinking about self-test kits as a screening, as a way to increase coverage. So I'm going to go to the next slide, and I'm sure Rachel will speak to this more later, but there are new WHO guidelines that are also supporting and offering, I want to say, reassurance to people who might have previously been hesitant about different ways in which self-test kits can be used. So the WHO is now saying up in the top left, self-testing may be used to deliver pre-exposure prophylaxis for initiation, for reinitiation, and for continuation. All right? And in guidance they released last year, they're highlighting the ways in which when we distribute PrEP, we can also distribute HIV self-test kits so people can continue PrEP without having to come back to facilities. And this could be used to support initiation or this continuation or event-driven PrEP. We also see in this new guidelines that HIV testing may be offered as an additional option for testing at facilities, which is again reassurance. In some places this is happening, but maybe not happening to its full potential. And at the moment, there isn't sufficient evidence to support caregiver-assisted testing for HIV self-test kits, but very strongly the WHO acknowledges that we have to look at our recommended approaches to do better at reaching children. So here's just some new guidance that we can feel reassured by. On the next slide, you'll also see that there's a new strengthened recommendation regarding social network testing. And we bring this up as one of the modalities or one of the channels in which HIV self-testing could be used more. So this is not a specific self-testing recommendation, but more how social network testing plus self-testing could be a way of reaching previously unreached populations. So on the next slide, just to wrap up here, we want to shift away from some of these things and some of the current way of doing business a little bit with self-testing, right? So we don't want self-testing to be bespoke or just for a few people and a few distribution channels. We also want to shift away from following every self-test kit that's distributed to see where it ends up and to see what happens with it. Because if it's used like that, is it really self-care? I would argue no. And so we're going to have to look at other ways of getting the data that we might want or asking if we really need all of that data from our self-test kits. And next, which is my final slide, is just to say that this is what we're shifting towards, right? So if that was shifting away, this is shifting towards. We want to have more use within core facility-based testing, more use within these prioritized testing approaches that we've spoken about, and more use within private sector and community testing approaches. We want to see if we can address age barriers to access for adolescents. And again, we want to use it for increasing access to PrEP, right? We shouldn't be making people just return to health facilities just for a test. So in closing, on the next slide, I want to thank all these people that gave me slides to use and gave me input. And you can go to the final slide, and this is me turning back over to Maya and your panelists for the discussion. Thanks very much.
Great. Thanks, Anna. I realized when I put the mic down, I introduced everyone but myself. Hi. I'm Maya Sundaram. I'm with the Gates Foundation. I lead our testing work there. So it's very wonderful to be here. And I'm sorry that I didn't actually introduce myself when I said hello. So what we're going to do now is we would really love to have this session be quite different, I think, than most of the sessions that we've had, at least that I've attended at the conference so far. And we would really like to hear from the audience. We have, as I said, just an excellent panel. We have the great presentation that Anna just gave. And while she tried to get away from questions, I will direct them to her if you have some. And And so my hope is that we can hear from all of you over the next 20 minutes or so, and then we'll give our panelists just a minute each to kind of give some closing remarks before the end of the session. So with that, I'll start us off just to kind of get the blood flowing, and ask and start off with one question. But let me start with Shailet, if it's okay. But I would really love to hear from you, Shailet, as we hear about realizing the potential of self-testing and thinking about opportunities for self-care and community empowerment, and we look at these themes from the conference, including addressing the inequalities, accelerating inclusion, and the potential for innovation. Of course, self-test in and of itself is an innovation, but there's so much more we could be doing. Can you give us your thinking and your thoughts, and from your community constituencies, what can we be doing differently and better?
Okay, thank you so much. My name is Charlotte Msiza. Working there as a Dreams Programs Officer. So, according to our organization, we work with KP population. So, speaking of self-testing has been quite. Hello, once again. I'm Charlotte Msiza from Seychelles, Zimbabwe, working with the KP population as a Dreams Programs Officer. So I will start by highlighting some experiences that the KP population have been experiencing since we started implementing this KP program. So according to Seychelles and the community as well at large, KPs that have issues of privacy and confidentiality, which we as Seychelles, we don't compromise with. So there are issues that maybe when it comes to self-testing, it provides privacy to the recipient of care, meaning to say you can test at any time, at any given time, at your own place. And also, we have issues of autonomy, meaning to say a KP or a recipient of care has maybe the ability to choose to have their own choices when it comes to self-testing. And also, it helps them with the decision-making when it comes to self-testing, meaning to say they are now solely responsible for their health. They are now solely responsible for their health, and also they are not, they're highly mobile, as we know, the KP population. So if you provide them with self-test kits, they can test themselves at any time, and also they stay informed of their health. And we also have the accessibility issues. As KP organization, we have managed to provide free self-test kits, ensuring the availability and convenience to the local or to the locations that of high priority. We also have educational and awareness campaigns, which develop comprehensive educational campaigns to the KP community. We also have inclusion of the KP in our programs, meaning to say they have an upper hand of the, maybe they have an upper hand of the targets or the indicators that we're dealing with. So there's peer-to-peer again. We use KPs to engage with the community. That is our community cadres. They help to facilitate the self-testing. They help to cascade the information about how important self-test can be. We also have cultural language. We also have language and cultural sensitivity, ensuring that self-test materials and support services are available and multiple languages and culture, meaning to say we can't have only one language, because we are dealing with maybe 70% of them, they are illiterate. So they need to have so many languages. Maybe we can talk of Shona in Zimbabwe, we can talk of Ndebele, we can talk of English. So as to provide services, that is tailored services to each individuals. We also have issues of privacy and confidentiality, which will go back to the stigma and discrimination. KPs often face discrimination and stigmatization. So as Seisha, we don't compromise with stigmatizing the KP population. So by that, we have the DICs at our sites, at our centers, and these DICs, we see them as a place of relaxation, our safe space as sex workers. So this will provide a lot of confidentiality. And also talking of confidentiality and privacy, we also offer clear communication to the recipient of care on how we are handling their personal information when we engage with one. Speaking of Sisha, we have this code, which we call a UIC, Unique Identification Code. Maybe if it's lost, you can't identify who this belongs to. So
Charlotte, I'm going to just ask you to stop there so that we can also make sure that the audience can ask some additional questions, and we'll come back to you at the end for some closing remarks, and obviously any additional questions that come to you just
okay.
now. So let me open it up to the audience. Charlotte gave us a lot of really great insight into the community needs around privacy, autonomy, accessibility, particularly for this highly marginalized and vulnerable group. But let me hear if there are questions from the audience, so we can also hear from our community members and other panelists. Oh, please
Hi.
go ahead, and then I have one here in the front.
Thank you so much for the presentations. My name's Yasmin Dunkley from the London School of Hygiene and Tropical Medicine. Anna, in your presentation, you brought up a really important challenge that has been levied at self-testing and the self-care agenda more broadly, which is about result monitoring and surveillance. Not only with HIV, but with other potential outbreak diseases that we saw with COVID-19 self-testing. So my question for you is, and I very much agree that the purpose of self-testing is about empowering the individual, and that also relates to whether or not to inform people about your results. So what do you say to ministries, to international donors, to other concerned stakeholders who are concerned about surveillance and monitoring more generally? And what's our response to that as a sector? Thank you very much.
Yeah, I think that's an excellent question, and maybe I'll actually turn it over to my ministry colleague here who's on the panel to respond, who's thinking about potentially surveillance and the questions that my colleague just asked. So Jeffrey, would you like to take that question? You think, I don't know if these ones, okay, well, let's just do this so that it doesn't make that sound.
Thank you very much, Maya, and thanks, colleague from Liverpool, for the question. I just want to make one statement, maybe before I respond, that the need to optimize HIV self-testing to drive prevention programs has never been greater than it is now. So it is time now that we rethink. And I'm glad that this panel is here today. So talking about surveys, and then I was here thinking about issues of impact and cascades and measurement, because these have been the things that sometimes make the whole conversation around self-testing quite unclear. And I like the statements Anna made that, we may not have to follow each and every self-test to see the impact, or where it went and who used it and for what. So it's very clear that some of the data will not come through routine program reporting for HIV self-testing. And I've been thinking probably as we do population-based surveys, for example, the PHIA, the FEAR surveys, Uganda, we should be doing ours next year in June. We need to think critically of how we can integrate measurement around HIV self-testing, the impacts, who have we reached, who is the self-test, so that largely we can be able to tell the story of HIV self-testing and its overall contribution to the HIV response and consequently to epidemic control. Before I give you the mic, I just wanted also to mention that as I listen to the presentation and different people speaking, I think there's one other thing that we need to think about if we are to optimize HIV self-testing, and this is communication. the human-centered design communication is something that we cannot run away from. So we've got to think about investments. In Uganda, we just did this in the private sector with catalytic support from CIF and part of the STAR 3. And we saw a huge rise in HIV self-testing utilization in the private sector. And speaking about self-care, personally, I see the future of this as, shifting to the private sector 2, 3, 4, 5 years from now. So human-centered design is such a game changer in HIV self-testing. And we must talk about it, we must invest in it, and we must do it.
Great. Thank you. It's a great question, I think, about surveillance and measurement. And I think, there are some innovations to be had there. But I think it is, as, Tasi mentioned, how do we get away from every single test, right? And are there innovative methods in triangulation that we need to be thinking about?
My question is simple. I'm Douglas Mapeta, sign language lecturer. My question is, what is being done to the deaf, to people with hearing impairment, looking at the technicalities of the language, medical terms, to the deaf and the medical team able to communicate with the deaf, and what is being done as far as this is concerned to people with disabilities?
I think it's an excellent question, and if it's okay, I'm going to turn over to John Bosco, who has a lot of experience hearing from countries who across the Sequin network that are experiencing similar challenges with people with disabilities, and how do we ensure our services, especially in this case self-testing, are accessible and usable for those colleagues. So John Bosco, if it's okay, I'm going to ask you to make some remarks.
Thank you very much for the question. So I'll start with what you asked. Usually when countries are designing their policies and operational guidance, there is an aspect which they put that caters for people with disabilities. And in their training manuals, their training materials, their standard operating procedures, they include the provision of services for prioritized populations. For example, people who have difficulties with sight and people who have difficulties with hearing. In addition to that, from the CP network, we've been providing technical assistance to countries, and we encourage cross-learning from one country to the other through different platforms. But when we talk about the future of HIV self-testing, we've seen that countries need a lot of support in terms of planning, both strategic planning and operational planning. In terms of strategic planning, is looking at envisioning where do we want to be in the next 5 years, and how do we embrace HIV self-testing to reach the testing targets in terms of case identification, in terms of identifying people who are at high risk, and customize prevention services to them. But we also know that there are some countries that have developed micro-planning for HIV self-testing. And there are some tools that we can actually get from those countries and share with other countries. So there is great need for micro-planning. They will do micro-planning for vaccination. And we need data, program data or survey data, well knowing our epidemic, the identification gaps, which people and which geographies are these gaps, and then we tether our planning to those. Of course, Geoffrey has mentioned about public-private partnerships. It is very important, and countries need the frameworks that help to engage the two. And we can adopt lessons from condom programming, the total marketing approach, social franchising, and we can have these self-testing kits in private facilities, private pharmacies at a subsidized cost. These can be accessed easily by the members of the public. And maybe lastly, cost subsidization. This is at higher level negotiation. We know self-testing kits were highly expensive. The price has reduced. And we thank all the bodies that have been negotiating. The Gates Foundation has been part of this. Thank you.
So I think an excellent point, but it sounds like there are some guidances coming from countries and some tools and approaches that countries are taking, and it sounds like, you know, in thinking about the question from my colleague, there's more that needs to be done in elevating what has been done well, but we continue to have some gaps for people with disabilities, and perhaps leveraging some of the insights work and the human-centered design approaches to really understand the needs of those populations is critical for self-testing and otherwise. I saw this gentleman's hand first, but or Anna, oh, and then maybe I'll come to my colleague here in the dress, and then to my other colleague. No, in the white hat there. Thank you.
Thank you so much. My name is Alan Matubu with the University of Zimbabwe. So I think as we talk about HIV self-testing in relation to PrEP initiation as well as continuation, we need to be aware of some of the challenges that we have started seeing in terms of difficulty HIV diagnosis in people who are on PrEP. So seroconversion in PrEP is very different from seroconversion without any intervention. So as we roll out PrEP, we are going to have this difficulty in terms of really establishing whether someone is infected or not. And at that point, I think it's going to be very complicated to rely on self-testing. So I'm talking from a perspective where we are really struggling within a research setup, where we have got a very elaborate algorithm to try and make an HIV diagnosis. And at times, you exhaust a whole algorithm and still you are not sure whether someone is infected or not. So I think we really need to discuss now. And for those who are into kit manufacturing, we need to proactively begin to think about, at a time when PrEP rollout has been so high, how are we going to be able to really make a correct and accurate diagnosis of HIV? Thank you.
That's an excellent question, and I think we have a panelist here, Rachel, who is very well positioned to give some comments. Rachel, I'll ask, just because we have two other questions and about 5 minutes, to try to answer a complicated question within a couple of minutes.
Thank you very much. And this is obviously a question we've looked at very carefully on these new recommendations. And I just want to say it's a balance always. We want to make the availability of PrEP, PEP, the Dipivrin vaginal ring, all as easy as possible for people. At the moment, unfortunately, about 50% of people start on PrEP and are never seen again. And the complications of coming back and people don't take PrEP for long periods of time. Often they stop and start and restart. And we do want to really support them to take PrEP in a way that is going to be effective for their prevention needs. And I agree. There are some cases where it's difficult if somebody does seroconvert whilst they're taking PrEP to make that diagnosis. But the vast majority of people who do acquire HIV while they're taking PrEP acquire it actually when they're not taking PrEP. That's why drug resistance is extremely low with oral PrEP, is because those seroconversions actually happen while people are not taking PrEP. So in a real world experience, and we want countries to really support this and to see how this fits in with their populations. We want people to start. Often the first time they're starting PrEP, it may be important that they have a consultation with a community health worker, a peer, so they can really chat about how to take it safely. Once they're experienced, to use self-testing from time to time, to use self-testing if they've stopped, to restart. And we really think there's massive potential for PEP, to use self-testing, to provide self-testing in the community with PEP. so that if somebody's had, sexual exposure, they can really start PEP as soon as possible. PEP is really not used much at all. It's really something that could, and there are some lovely projects now happening in South Africa and Kenya, where PEP is being offered in pharmacies, and it's really getting to men. And people can start PEP much more quickly if they have access to self-testing. They don't have to wait till the clinic's open on the Monday morning if they've had an exposure on Friday night. And this is really going to help them. So co-marketing PEP and self-test together, we think is something that will really help in the antiretroviral prevention landscape. CAB, it's a very different question. And I think, CAB LA, lots and lots of questions about how we test at all on that. We do know there are real complications, but with oral PrEP, it's much less of an issue.
So I think a really excellent question, but as we think about, we need to maintain that balance, I think that Rachel just mentioned, and with high quality services and obviously ensuring that we're monitoring for seroconversion, but recognizing that PrEP is also highly effective. And I love the plug for PEP. I am a big fan. So I think, but really, I think excellent question. I think we had my colleague here, and then we'll come to you.
Thank you. My name is Primrose with SESHA Zimbabwe. It might be a follow-on question to my colleague. I wanted to say it's really great when this new guidance comes out, and we're often eager to see how we could use it. What can we do, and which actors need to do what to bridge the gap between the guidance and the use and navigating concerns within countries? Thanks.
I love that question, and it was one of my own in case everybody was quiet this morning. Rachel, that comes back to you, actually. So let me give this back to you. And then actually, Kelvin.
Thank you, Primrose. It's a really interesting question for WHO. We make guidance, but WHO itself doesn't make guidance. It's made by our guidelines review committee, which consists of people like you, people from ministries, people from communities, researchers. And it's always based on everything that's available at the time. We do a huge amount of background on values and preferences, on all the literature. So we're very confident that it's state of the art. And it's then often a bit of a challenge. And some countries are early adopters. Sometimes countries are before us. They've actually done, doing what we've recommended before us. And these, and then there's a whole load of countries that come in quite quickly. And then there are other countries that are much more reluctant for a whole range of reasons. More conservative, they're more worried about, for example, maintaining lab control. So each country we have to navigate in different ways. But we're here at WHO to support countries, to reflect what communities want us to push in ministries. So we're here in this conference with a lot of my Afro colleagues, and this is what we do on a day-to-day basis.
I'm realizing that we have very limited time, and I want to make sure that Kelvin and Taryn have a chance to make a comment as well. I may have to come to your question in an informal session after the session is finished. Kelvin, maybe you could speak to this question as well, because as a partner, you may have experience with your ministry in Malawi. I'd love to hear from Tasi, but I want to ask Taryn a separate question afterward.
Thanks so much. I think what I can say to that is, I think it's also important for countries to think about what is their situation. And so it's important, I think, when thinking about guidelines, to think about how do they translate specifically to our situation. I also just wanted to make a comment on the issue that was made earlier about patient-centered counseling, for example. I think one of the most important things that we also have to think about is how do we continue providing services beyond the facility. And I think one of the gaps in self-testing is if you're in the community, how then do you continue getting more information about what your result means and how can you move forward beyond that? So thinking about strategies in which we can continue offering these services or information beyond the facility setup will also be important in this. Thanks so much.
So I'm going to just take my moderator privilege and ask Taryn a last question because we're running short on time. But we're seeing so many questions, I think, about implementation, yet obviously all of this comes with questions around funding. And as we think about the themes coming out of this conference, but well before this conference, in the context of sustainability and transition, how can we think about, as this group of funders and implementers and country leaders, what that means in the context of self-testing, especially recognizing that it can be revolutionary. We are seeing reduced incidence. We are seeing the effectiveness of treatment. We do need to see an increase in prevention, as Rachel and others noted. And so how do we balance that need to scale up self-testing with this need to think about how to sustain all of what we've achieved to date?
I think you might have saved me the hardest question. I think there's a number of things that we can do, but the reality is we're in a very difficult place on funding, and we're coming out of a world where we've gone so deep on yields and positivity being so important, and we're finally coming back to this world of status neutral testing at the same time that resources are limited. I think, one, there's places for more innovation around products and packaging, especially as we move into facility-based testing, so you don't need individual packs of products, which could dramatically lower the price of products. I think number two, the work that we're starting to see in the private sector and that people are willing to pay if you build this narrative and messaging around testing being part of wellness. And it's not something that's always on the public sector to have to do is incredibly important as well. And I think we'll see that trend, as Tassi was saying, towards much more private sector use of testing. And then I think finally, it's about really looking at community delivery models and looking at very much your service delivery models. What are the least expensive and most community-driven ways to get products into the hands of the people who need them? And I think focusing on these different areas will really help us drive towards it, while also continuing to pass the message that Anna had, that actually it is more cost-effective to continue to invest in testing, or we're going to get further behind.
Thank you. And I know we're a minute over time, so I won't try to fully summarize the depth of the insights that came from the session, but we heard about measurement and surveillance. We heard about community engagement and the community's needs. We heard about demand and literacy and the need to really have strong insights from our populations and ensure that we're addressing the issues of the inequalities. We're hearing about prevention. Prevention is, we will not reach our goals in this response without scaling up prevention, and removing the barriers, including the use of self-testing for prevention, will be critical. The barriers for self-testing itself that I think Taryn was really just speaking to, in terms of reducing the prices, making it more accessible, thinking about the policies that will enable us to have self-tests more universally available to people, I think is going to be critical. So I know I have missed some really great points that came from some of our speakers and from some of our audience members, but hopefully many of you captured those in your notes as well. Thank you all for coming. I'm sorry we're 2 minutes over, but it was a great session and a great set of panelists. So thanks to my panelists and thanks to Anna.
How are you?
We're here together.
Sure, you want to just email and I'll send it to you later?